Good day, friends of Buzzy. So if you've been following along with our COVID videos, you know that if I'm wearing my doctor coat, I'm going to be talking serious science. Today, I'm talking about the coronavirus vaccine made by Pfizer and made by Moderna. So let's review. We have a Pfizer vaccine, which was not funded by Operation Warp Speed, but an order was put in when they developed the vaccine. We have Moderna, which is not only funded by Operation Warp Speed, but also Dolly Parton, what? And both of these are mRNA vaccines. Let's talk about what that means, why they have to be transported in such a cold form, when and why and how I am likely to take this vaccine. All right, so let's start with the issues of what is an mRNA vaccine. There's never been a human mRNA vaccine approved. It is, however, made and approved and used in animals. The difference between an mRNA vaccine and a normal vaccine is that a traditional vaccine is going to take parts of the virus itself that are not themselves able to infect you, but they are able to be recognized by the body. They give you that, your immune system sees these foreign parts, learns to recognize them, and then is ready to go if that ever shows up again. It's kind of like a regular vaccine prints and distributes wanted posters, and then your immune system goes, takes the posters and puts them up in all of the immune systems throughout your body. All the T cells go, okay, we see that guy, we'll get him. mRNA vaccine is different because what an mRNA vaccine does is they actually take the genetic code of the wanted poster and they put it, because it's unstable, they have to wrap that DNA in a lipid layer, a fatty layer. And that's why it has to be really cold, because that fatty layer can melt and then the raw DNA is just sitting there. So instead of a vaccine distributing wanted posters that then get disseminated everywhere, what an mRNA vaccine does is it has a QR code, and the QR code goes into the cells. The cells then make the wanted poster, and then the body reacts to that and says, okay, now we got it. If we see this again, we have it. It's a little scary to think about just putting in DNA, or mRNA in this case, but putting in genetic code and then having your own body manufacture, in this case, the spike protein that you want your immune system to recognize. However, we have been doing gene therapies, and we've been imprinting little tiny small snippets. And this is not like DNA. It's not going to change your code. This is a very specific kind of, basically like what the cells do all the time. They make proteins. So this is just saying, you know, instead of the normal protein you're making, here's a protein that will then be recognizable as foreign spike protein from the SARS-CoV-2 virus, and then that can be attacked. So it makes sense, and it also makes sense that it's not going to cause long-term problems. Now, why were a lot of people, myself included, not interested in getting a vaccine early on? It was not because of politics. It's because when you're looking at respiratory viruses, particularly viruses that have a strong immune competent issue, your immune system is sometimes what's causing you to get more sick. For example, there's a disease kids get called bronchiolitis, which is caused by respiratory syncytial virus, or RSV. The initial vaccine for RSV back in the 80s, I believe, went through the tests, but when they gave it to babies, when the babies actually got RSV, a certain number of them, their immune system went so crazy that they got worse. So this is called immune enhancement. Your normal immune fighting system is enhanced and goes too far. If you've seen the Will Ferrell movie, Saga of Fire Saga, the elves have gone too far. Well, that's what's going on with your immune system with some of these vaccines. When it's a respiratory virus, turns out that the mRNA vaccines, no one got immune enhancement who got sick. So there was not a problem of having worse disease with this. The other thing is that we've done a pretty good job of identifying people who have enhanced immune responses. We're giving them Decadron. So even if there were a concern, I feel like that's the one part of this that therapeutically we've gotten figured out. I am not concerned about immune enhancement with an mRNA virus or vaccine. Second thing, how legitimate has this process been, and how trustworthy is the process from a regulatory standpoint? I think it is telling and sad that the major regulatory high ground in this whole process has been done by the drug companies. Many of the drug companies noted that they were not going to apply for an emergency use authorization from the FDA until they themselves had equivalent rigor in their scientific evaluation of the vaccines as with any other vaccine. So besides the fact that we're past the election, the current thing that is reassuring to me is that the drug companies themselves have been the ones who have wanted to not cut corners. We have 30,000 people enrolled in the Pfizer vaccine. That is plenty. The number of people who caught the virus and got sick, 95% effective for Pfizer, 94% effective for the Moderna. It's the same process. It takes a long time to make it. At this point, once they have submitted their data, it's going to be reviewed in the same way a scientist would always review data. It's not actually that hard to look at the cases. They are sequentially numbered. You can say, where did this person go if something happened? I feel comfortable with the peer review process looking at the vaccine results. And the other thing is that both of these vaccines should actually work in a similar fashion. So the fact that both of them had 94.5, 95% efficacy is not only reassuring, it's also, it supports the science. I would feel very concerned if they had really different similarities, given that the process of making them is the same. Now, the process of making them is not going to be exactly the same, because why does Pfizer have to have a -70 Fahrenheit, negative 70 Celsius, -94 Fahrenheit freezer to keep that lipid layer like an M&M coating the mRNA? Why does it need to be that cold when the Moderna one only needs to be -20, which is normal freezer cold? I don't know. First of all, it could be that the Pfizer one actually doesn't need to be that cold. It could be that it's because the Moderna people have been making mRNA vaccines for longer, so they've got more experience. So maybe there's a more stable. Certainly could be that Pfizer has not tested their stability in a warmer freezer, if that's not an oxymoron. And so therefore, they don't know yet. So they're just being careful. But this leads me to the next part, is how and when will I get this vaccine? It is really important for everybody to know that the vaccine has 2 doses, and it's sort of like the shingles vaccine, if you're familiar with that, in that about 15% of people are going to have seriously sore arms for the first day. But the second dose you get, your immune system is primed, and you're likely to feel like crap for a weekend. You're going to want to get it on a Friday so that you can feel sick. You may even have fever over the weekend while the final immune safety push goes into your system. The other part about that is when you've got a vaccine like that, they tend to cause more site reactions. What is a site reaction? It's at the time you get it, it can be extremely intensely painful. So I don't necessarily remember to bring a Buzzy when I'm getting a flu shot, but I will definitely be taking a frozen ice pack, which for injections is about 50% of the numbing, and a Buzzy, and I'll stick it on for about 30 seconds. I'll slide it up, and then I'll say, fine, give me my shot, I'm ready. And I will look away and all that, because we are more likely, because it's a more painful vaccine, to have more fainting, more vaso-vagal symptoms, that sort of thing. And so we want something to stop not just the pain, but also try to interrupt that sympathetic stimulus or that parasympathetic stimulus with the sympathetic vibrations and the frequency of Buzzy. When will we be getting it and where? Well, the where part is going to be limited by those freezers. Currently, not every rural hospital has a freezer that is capable of -70/94. Most big city hospitals are going to have that kind of intensity of freezing, but there are a lot of wealthier neighborhoods and areas that are apparently buying up -70, -94 freezers as we speak. Now, I was contacted yesterday by the Georgia Department of Public Health asking if I wanted to be a vaccine administrator. I am not seeing patients, so no, and even still, it would be pediatrics, the last on the list to get it. But there is definitely a current push to enroll people who need the vaccines and the freezers to hold them. The likelihood is that more rural areas are going to have a harder time finding money to purchase the freezers, finding available freezers if they do have the money, and so that may further delay delivery. Pfizer is packing its vaccines in little styrofoam tubs and packing them with dry ice. They say that if you replace the dry ice every 14 days, that those little to-go boxes are good enough. That may obviate some of the problem in the more rural areas. Who is going to get the vaccine first? I think people probably know by now that 100 million doses have been purchased by the government from Pfizer. That's 50 million people who can get it. And so, because you need two. And so there certainly is going to be a preference for both of these vaccines that people in nursing homes, people over the age of 85, and then it's probably going to work its way backwards based on risk category. So we're going to do age first, and then most likely male, female is kind of meh. The interesting question is going to be whether the clear 2 to 3 times death rates in Latinos and Black populations, whether that is going to be acknowledged. Anybody who has renal disease, diabetes, those are people that are at higher risk. Those will be no-brainers, easily put on. Hypertension is not actually seeming to be a risk anymore. I don't know if that'll be put on, but the exact criteria of what risk categories matter the most, obesity certainly should be up there. It's one of the higher risks of having severe risk of hospitalization, morbidity, and mortality. In considering who is getting the vaccine, it's not just who is more at risk. It's also who are we seeing taking up time and room in emergency departments and ICUs, particularly in ICUs, because the number of days that people are in the hospital and in the ICU, that's a bed that somebody else can have. We're going to have some degree of a calculus that may or may not become public, but it will involve how many days are people on the ventilators taking up space. Obese patients take up more space, and not physically, but there are more obese patients on ventilators. There are more obese patients who are hospitalized for 3 weeks before either leaving or dying, rather than other patients, older patients, patients with underlying kidney disease. Those people seem to die faster. So that may very well figure into the issue, not who is most at risk for their sake, but who, if we treat them, if we give them a vaccine, who's less likely to be taking up space and a ventilator and resources that could save 3 people in the meantime. These are the times we live in. These are the kinds of discussions that need to be had. And I, again, would not be surprised if they're not public, but that's what's going to be talked about. Where and when am I likely to get the vaccine personally? Because of all the forestated comments, I will be fine. As soon as my time comes up in line, I'll grab my Buzzy and I will get to wherever I can be vaccinated. I am in a big city in Atlanta. I'm likely to get this sooner than other people, but I'm 52 and I don't have underlying health. I'm 51. I'm in my 50s and I don't have underlying health problems. Therefore, I guess, my best guess is that I am not going to be eligible for a vaccine, honestly, probably until the fall. If it's sooner than that, great. But I think that the fact that Joe Biden is not getting briefings from the current coronavirus task force, the fact that they're not meeting as frequently as they should be, the fact that the current vaccine Operation Warp Speed guy says he's going to step down, but he's not briefing them, I think we're going to lose a month or two of efficiency because of the failure for the outgoing administration and the incoming administration to be able to sync up like the ISS space station and Dragon and get their act together. Therefore, I think that people my age are likely to not have availability of the vaccine until the fall. It is what it is. That's a lot of information right there. If you have any questions, please put them in our chat box. Please put them in the Facebook or YouTube. Also, if you want to know how to use Buzzy to take a vaccine, whether it is flu or COVID, and if you haven't gotten your flu, see my video about why you should get flu. But we also have a freaked out about flu shots, the science about why Buzzy blocks pain and fainting from injections. There you go. It's been a pleasure helping us get through this whole COVID-19 process. We are not out of the woods yet, but I am absolutely positive that we're going to be going crazy nuts by next fall, traveling, having parties, being around each other. And until then, I am incomprehensibly devastated that we are likely to have 400,000 people die from this before this is all over. But I see the light at the end of the tunnel, and it's going to be fine.